Regarding practical considerations, of course, there are emerging data on how to use CAR T cells in the best way. There were, of course, several interesting presentations, and we also had a symposium, satellite symposium, shedding some light on these issues. What I found very compelling were the data from the French Descartes study with 550 patients receiving CAR T-cell products in routine. The French colleagues have really managed to, let's say, select patients in a very good way so that they can keep up the progression-free survival to, I think, 44% and overall survival at 6 months to 83%. That's remarkable. So patient selection, of course, in practice is important. On the other hand, what was also shown in the French study is that of those patients who would not be optimal candidates, for instance, because they progressed heavily before they received the CARs, 30% of patients had long-term control. So I think for practical reasons, it's important to find the right balance between excluding and including patients into CAR T-cell treatments. There are helpful factors, patient-related, treatment-related, product-related factors that will guide us through this selection. And I think this will probably be the most important way. We also talked about some toxicity issues and when to apply CAR T cells and when to apply, for instance, tocilizumab and steroids. We've learned through real-world evidence that, for instance, for the tisa-cel, the toxicity can be kept very low when managed properly. Same goes in principle for the other products as well. And then we also had some case-based considerations on who would be a good candidate for CAR T cells. Also, for instance, transformed lymphomas seem to respond very well, etc. In terms of integration of the CAR T cells into the treatment algorithm, of course, there are things that will move us forward. Currently, we are still waiting for the big randomized studies comparing CAR T cells against autologous stem cell transplant.